Psychology. Um, and I also have an appointment in the Department of Psychology as well. I'm really excited to be here with you today and to talk to you a little bit about implicit bias and some of the research surrounding this topic. So I'm thankful that Lynn invited me to come and present to you today. Hopefully you'll learn something. Hopefully it'll get you thinking about something new that you hadn't thought about before. But I will take questions at the end if you have questions about anything that I talk about today. And I tried to make a point of bringing in some things specific to pharmacy. Most of the research in this area really has been done with physicians, but I did try to integrate some conversation looking specifically at how this bias works among pharmacists as well. So I'll go ahead and get started. All right, so what I want to do, just to give you an overview of what I'm going to talk about, I'll start by just laying the groundwork and kind of talking about what implicit bias is and what it means. Then I want to move into talking about how we actually measure implicit bias. And then I want to talk about why we care about this topic. Why does implicit bias even matter when we're talking about healthcare settings? And then I want to end by just talking about strategies that we can potentially use to reduce this type of implicit bias and the discriminatory practices that may result from it. So what is implicit bias? So I want to start off by just talking about bias generally. And we all have biases, and not all biases are necessarily harmful. If you gave me a handful of jelly beans, for example, I would tell you that I have clear biases. I am very much pro-orange jelly bean, very much anti-pink jelly bean. If you gave me a pink jelly bean, it's probably going straight into the trash because I do not like pink jelly beans. And so we all have biases like that. We all have a favorite treat. We all have a favorite drink that we like. But biases like that are pretty benign. They don't harm anyone. But we have biases about most things that we do. We have biases that are based on all kinds of experiences that we've had. So bias in and of itself is not necessarily a bad thing. It only becomes a bad thing when we use it to discriminate against others or to behave differently towards others in ways that negatively impact them. So I want to talk about also what it means to say that a bias is implicit. So to do that, I want to first talk about explicit bias. So an explicit bias is a bias that you're very aware of, that you're very open about. I openly hate pink jelly beans. I don't want to have them ever in my hand. I'm very aware of these thoughts and emotions that I have towards them. And so explicit biases are really the biases that we're aware of that we may have towards specific groups. At the extreme end, they result in hate speech, they result in actively discriminating against other people, and they lead us to sort of have prejudices and stereotypes about specific groups. Implicit biases function a little bit differently. We're not aware of these types of biases. These are those gut reactions that we have that occur very, very quickly within milliseconds. But they're attitudes and beliefs that we have that impact how we feel, how we behave towards people, and how we judge them. And because these biases, we have these unconscious attitudes, these biases in some ways can be more dangerous because we're not aware of them. And so we don't know that we have them. And not knowing that we have them is really dangerous if we talk about the impact that they can have on other people. So the important thing to think about when we're talking about implicit bias is that it really operates outside of our conscious awareness. So if we think about the human brain, we engage in lots of automatic processing based on our previous knowledge and experiences. It's why you're every day able to get up in the morning, go out to your car and drive to school or work without having to think about it too much. So engaging in this type of automatic processing is really beneficial for us. It helps us do things faster and more efficiently. So having this type of automatic processing is not a bad thing. But unfortunately, we often extend that automatic processing to how we engage with other people. And so when we use these biases, we're often making these quick mental associations based on demographic characteristics. And this can influence how we treat people. So we make decisions about who's good or who's bad or who has positive or negative attributes. And we do them very quickly without realizing it. And what's important to know about implicit bias is that we make these connections between concepts, even when they are not in line with our explicit values. So we may not say or even believe that we have biases towards certain groups, but we still may have these biases, and it's these implicit biases that still impact how we behave towards other people. So research tells us that most people tend to show favoritism toward people that they think are like them. We call these our in group. So people who are the same age as us, the same race, the same gender, people who look like us are the people that we tend to show favoritism toward. And we tend to have negative bias towards other people, people that we perceive to be of the out group. So people who aren't the same age, aren't the same race, aren't the same gender. And from an evolutionary perspective, that makes a lot of sense. It's very adaptive to know who's a member of your group and who might be an enemy. You know, if you're talking about survival of your specific group, it's important to know who are the people that you can rely on for support versus the people that you needed to watch out for. So the in-group, out-group dichotomy makes a lot of sense in certain circumstances. But given the world that we live in today and the nature of the fact that this is a global society that we live in where we interact with other people, this in-group, out-group dichotomy can cause a lot of problems in terms of how we interact with others. So what are implicit biases based on? Really, you can have implicit biases based on all types of demographic characteristics. So you can have preferences for people based on race. You may have a pro-white bias or a pro-Black bias. You can have biases based on sexual orientation. So you may have a bias towards straight people or gay people. You can have bias based on age. So in our society tends to prioritize younger adults as opposed to older adults. You can have bias based on appearance. So do you have a preference for people who dress a certain way or who are of a certain body size? You can also see biases based on disability status. So do you have biases toward people who use wheelchairs or people who don't? You can also have biases based on gender identity, as well as gender. Often what we see with biases based on gender is that we may have ideas about the types of activities that women should engage in as opposed to the types of activities that men should engage in. And so we all have these different types of biases operating at the same time within our brain, and we often use these to make decisions. So now that we've talked about what implicit bias is, I want to talk a little bit about how we actually measure implicit bias. And the dominant way that psychologists measure implicit bias is using something called the implicit association test. And some of you may have taken one of these tests before. It was developed by psychologists at Harvard. And basically what you do with this test, it's a test of reaction time. And so anyone who takes one of these tests is given two tasks in random order. And so if we look at the task on the left, basically what happens with this task is that the person is sitting at a computer and they have their hands on the keyboard. And with the left hand, you're supposed to tap the keyboard whenever you see an image of a Black person or an image of a word that's related to something bad. So you might see a word like horrible or disgusting or ugly. And then the person is supposed to tap the right side of the keyboard when they see an image of a white person or a word that means something good, like beautiful or lovely or kind. So that's the first task. And again, these are given in random order, but that's the first task. On the other side of the screen, on the right side of the screen, we have a different task. This time, the person who is at the computer is asked to press the left side of the keyboard if they see a white face or a word denoting something bad. And then they're supposed to press the right side of the keyboard if they see a black face or a word that means something good. And what we find is that people have different reaction times to these two different tests. So a person with a pro-white bias, for example, has a lot more trouble with this task on the right than they do the task on the left. It's easier for them to assign black as bad and white as good. And you'd see the opposite in a person who had a pro-black bias. And so essentially what the researchers do is measuring the reaction time, how long it takes people to tap the keyboard in response to the different types of images and words. And so again, the IAT can be used for all of those demographic characteristics that I just talked about. So they have an IAT for sexual orientation, disability, age, and lots of other demographic characteristics. But these tests are really the predominant way that researchers measure this implicit bias that people might have towards specific groups. And I want to show you some of the results of some of these tests. Here we have scores when people are given the IAT to assess their preference for European Americans versus African Americans. And this distribution summarizes scores from more than 3 million people who completed this task between 2002 and 2015. And what we see overall is that people overwhelmingly tend to display bias toward European Americans compared to African Americans. Only, I think it's 14% or so of people actually showed preference for African Americans over European Americans. And about 18% of people are neutral when they do this task. And here's another one looking at responses using the IAT that's focused on straight and gay people. And we see something similar. Overwhelmingly, people show a bias towards straight people over gay people. And again, about 18% of people show no real preference for either straight or gay people. And then finally, we can look at the gender IAT. And so for gender, usually what they do is measure the extent to which people associate men with career and women with family. And what we find is that people tend to embrace these sort of traditional gender norms, that men are more likely to be associated with career versus being associated with family. Only about 6% of people associated men more with family than they did women. And so here's an example of the task that they use specific to gender. So they might get a word like salary, and they have to recognize that this goes in the category where female and career is in this task. And people tend to have slower reaction times, and it's more difficult for them to correctly assign the word salary to this grouping of female and career together. All right, so we've talked about what implicit bias is. We've talked a little bit about how we actually measure implicit bias. And now I want to talk about why we care about any of this at all. Does this matter? What does it mean to have people do these computer tests? And does it tell us anything about our behavior? So now I want to talk a little bit about why we actually care about this in the context of healthcare. So implicit bias matters because research studies have really shown that scores on these implicit association tests that I've shown you are strongly associated with how healthcare providers actually interact with patients. So people who tend to have more pro-white biases tend to display different behaviors towards Black people, for example, or people who have more pro-straight biases tend to display different behaviors towards gay people. And so I want to just show you a few examples of that. So the first study that I want to talk about, actually, it was a study that was conducted in academic medical centers in Boston and Georgia. And so the physicians in these studies were given an IAT, they were given the race IAT. And they also looked at data on the extent to which these physicians offered thrombolytic drugs, which are designed to reduce blood clots among Black patients with heart attacks. And what they showed is that physicians who had more implicit bias toward white people and negative biases toward Black people tend to be less likely to treat Black patients with these drugs. And what's really interesting about this study is that in addition to using the IAT to measure implicit bias, they also asked people about their explicit bias as well. So they asked them, how warm do you feel towards Black people on a scale from 1 to 10? Or how warm do you feel towards white people on a scale from 1 to 10? And what they saw is that explicit bias, asking people how they felt about people from different racial groups, that bias did not predict their decisions. But what really predicted was the implicit bias as measured through the IAT. So these biases that we're really not aware of seem to predict how we provide treatment and care to people of other races, even more than the values that we actually state out loud. And so that's why implicit bias is really important to think about, is because it's something we're not aware of, but that happens all the time, and it directly impacts how we provide care to other people. Let's look at another study. So this is another study that was actually conducted here at Wayne State in the oncology department. And this study was conducted among oncologists. And again, these oncologists were administered the IAT. And they measured a number of things. So they looked at pro-Black versus pro-white bias, and they looked at its impact on how providers communicated with patients, and even the length of interaction with patients. And what they found is that oncologists who had more pro-white bias, as measured through the IAT, provided less supportive communication to Black patients than they did to white patients. And additionally, they didn't spend as much time with Black patients when they had higher scores on the IAT, when they had more implicit bias. And most importantly, when we think about how patients reacted to that and what the results were for patients, we found that patients were less likely to report that they had a patient-centered experience while interacting with that healthcare provider. And as a result, they remembered less of what the conversation was about. And so we're seeing here direct implications for the extent to which people are able to engage with treatment and engage in advocating for their own health. So this is a really important example of why this implicit bias matters, because it really impacts how providers communicate with patients, and as a result, how they feel about the patient care experience. And then one more that I wanted to show you, which I thought was really interesting. This was actually done among pediatricians. So these are people caring for children who are also administered the IAT. And they're asked questions about their own explicit attitudes and stereotypes. So they're asked about how they feel toward African Americans and European Americans. And these pediatricians then also took the IAT to get the measure of implicit bias with respect to race. But what was interesting about this study involved administering case vignettes. So participants were randomized and they got 2 case vignettes, 2 where the patient being described was an African American. And again, these are children we're talking about. And 2 in which the patient was described as white. And the researchers who designed the vignette intentionally designed the case so that there was some degree of clinical uncertainty. And the reason for that is that often when we think about implicit bias, it really seems to matter most when healthcare providers are dealing with situations where there's some degree of ambiguity. And so they purposely designed the case vignette so that there was some kind of clinical uncertainty within all of the descriptions. And what they found is that the pediatricians who had more pro-white implicit bias were much less likely to prescribe narcotics to Black patients than to white patients. And again, we're talking about children. So having these biases related to race happen even when we're talking about little kids. And so I thought this was a really interesting study as well. That just highlights the fact how durable these biases really can be. So I looked for studies that explicitly talked about implicit bias among pharmacists, and there actually hasn't been much research in this area specific to pharmacists. But I do think that implicit bias really matters when we talk about pharmacy as well. We know, especially in marginalized communities, pharmacists are often really the most accessible healthcare professionals. Pharmacies are located in many of our communities, and pharmacists often function as proxy physicians for people who may not be able to afford to see a medical provider, or who may not have time to go to a doctor's appointment. And so these biases really matter when we're talking about pharmacists, especially community pharmacists. But there actually hasn't been a lot of research specifically on implicit bias. But we do see that there has been work done specifically focused on discrimination and perceived discrimination in terms of interaction with pharmacists. And I want to talk a little bit about that. So one study that was conducted, it's a cross-sectional study of US adults, and these researchers were really interested in understanding the factors that were associated with delaying or foregoing prescriptions. And so the biggest predictor from this study was conducted in Durham County, North Carolina. And they looked at lots of demographic characteristics, including race, economic restraints, health status, and the biggest predictor was perceived discrimination. So people who reported that they thought the healthcare system treats people unfairly based on race or ethnic background were twice as likely to delay filling prescriptions or to avoid getting prescriptions filled altogether than those who had those lower levels of perceived discrimination. So even though there aren't many studies looking explicitly at implicit bias, we do see that feeling as though you're being discriminated against, which is the end result of implicit bias, has an impact on how people adhere to medication regimens. Here's another study that was actually conducted that was focused on community pharmacists. And in this study, which actually came out last year, the authors looked at perceived discrimination in community pharmacy, and they looked at demographic factors that might predict feelings of discrimination. And they found that age, sexual identity or orientation, ethnicity, annual income, and insurance were all associated with perceived discrimination in the community. And what was really important is that when they looked at these data, that there were a large number of people who reported that they had experienced racial discrimination while being in community pharmacies. And as a result, people kind of talked about the things that they did in order to avoid being discriminated against. And they talked about things like being careful about their appearance and really preparing themselves to be vigilant in advance about the issues that they were likely to encounter in the pharmacy. And what they found in this study was very similar to the last one, is that people who perceived that they were discriminated against in the healthcare system were much more likely to delay picking up prescriptions than those who did not. And we know that when people delay getting their prescriptions, that there are strong links between that and non-adherence. And so just having this negative experience within a community pharmacy has implications for, again, how people adhere to medication regimens, which can affect their health. And so when we think about sort of groups that can be potentially impacted by bias from pharmacists, a number of groups come to mind. So there have been studies looking at perceived discrimination from racial and ethnic minorities, also studies looking at LGBT individuals and how they feel about interacting with pharmacists. There's one study that I reviewed that talked about LGBT people who were going to get pre-exposure prophylaxis and feeling as though they were judged by the pharmacist for wanting to get this kind of medication, as well as people who might have opioid use disorders. The extent to which pharmacists would judge them for having these disorders really impacted whether people decided to go into pharmacies and get prescriptions that they needed. All right, so I've talked a little bit about what this bias is, how we measure it, why it matters, and I want to finally just talk about what we can do about implicit bias. There are a number of strategies that have been proposed. Some seem to be more effective than others, and so I want to talk about some of those strategies. So when I talk about implicit bias to patients, I give patients recommendations on how to handle this implicit bias that they're concerned about when they go into a healthcare organization. And some of the things that I tell them are first to be their own best advocate. So, making sure that they're informed about what's going on, bringing a family member or a friend with them to appointments so they can advocate to get the care that they need. I also talk to them about the importance of tracking their symptoms and coming to appointments prepared with lists of questions and concerns that they might have. And then finally, I also tell patients, not to be afraid to change providers or to get second opinions if they feel as though they're not being treated well. But most importantly, I make sure to tell patients that ultimately addressing implicit bias is not their job. It's the job of providers and the job of organizations. And our providers and organizations really have a responsibility to address these biases within their organizations. And so I want to talk a little bit about what providers and healthcare organizations can do to address implicit bias. So the first thing on the individual level that people can do is just become aware of your biases. And so I mentioned before that there are IATs for all different types of demographic characteristics. And so I think it's important for all of us to become aware of where we might have biases. That's the very first step. So do you have a bias towards certain groups? And sort of being really conscious of that, even though these are biases that you may not think you have, you may be surprised. So on the individual level, I encourage people to take different versions of the implicit association test so that you can see kind of where your biases lie. Second, on the individual level, we encourage people to engage in more intergroup contact. If we think about that notion of the in-group versus the out-group, one of the best ways to reduce feelings of otherness when we're talking about people who don't look like us is to interact with more people who don't look like us. And so that's why diversity matters, in terms of where we go to school, where we work. We all live in Metro Detroit, which is a fairly segregated metro area. And so we're generally surrounded by people who are very similar to us. And so on the individual level, really engaging in more contact with people different from us seems to help in terms of how we treat other people. Research and studies have shown that when you're around people from different groups more often, you have more empathy from people for that group, and you have more positive emotions toward that group as a result. And so again, on the individual level, we encourage people to engage in more intergroup contact. Another thing on the individual level is really just avoiding making decisions when you're more susceptible to bias. And so in general, we rely on our implicit biases more when we're experiencing cognitive load. So if we're hungry, if we're tired, if we're feeling time pressure, if we're distracted by other things, all of those things really cause us to sort of engage in more automatic processing just because we don't have the bandwidth to focus our attention when we have these other things going on. And so again, on the individual level, we encourage people to avoid making decisions about care and about treating people when you feel as though you're under more of this cognitive load. So I've talked about really these individual level interventions so far. But really the question that we should ask ourselves is, are individual level interventions enough? And really the findings related to this are mixed, and there aren't really clear indicators that doing things on an individual level is enough to reduce implicit bias in ways that are actually going to reduce discrimination. And so as a result, there really is a charge for organizations to make changes. And so I want to talk a little bit about what organizations can do at the institutional level to combat these biases and the discrimination that often results from them. So I talked about cognitive load on the individual level, but organizations can also engage in practices that reduce cognitive load, especially when we're talking about the staff of organizations. So probably the biggest reasons that people often feel time pressure or tired is because they don't have good staffing within organizations. And so improving staffing within your organization is one of the things that's really important in order to reduce the load that providers experience. Also, just engaging in continuous listening with staff is really important, and being responsive to feedback. Whatever organizations can do to make things easier for the people that work for them, that can have implications on the extent to which they rely on this automatic processing, as opposed to really taking the time to listen to people and think about them as individuals. Another thing that organizations can do is really streamline organizational practices. So if people have too many things to focus on that don't make a lot of sense, that tends to result in increased cognitive load as well. So as much as possible, if organizations can really streamline the things that they require their staff to do, that can have implications for cognitive load as well. Another thing that's really important with organizations is really thinking about training staff on how to care for diverse populations. This is a study that was conducted among community pharmacy residents to understand their perceptions of transgender health management. And in this study, what they found is that pharmacy residents believed that transgender patients deserved good care, and they felt as though they had a responsibility to treat transgender patients, but they didn't feel as though they had much education about transgender patients in pharmacy school. And additionally, about a third of residents said that only a third of residents said that they felt confident to treat transgender patients. So really focusing on integrating training of caring for diverse populations into healthcare education is a good practice for organizations as well. And then also on the institutional level, another recommendation is to create and follow policies and standards. What we know about implicit bias is that we tend to rely on this bias when we're in situations that are subjective or ambiguous. So if there are not clear guidelines on when a treatment regimen should be implemented, it makes it more fuzzy for providers. And so then they have to rely on these biases, these preconceived notions about people to make decisions. And so as much as possible, if organizations can have standards and policies that guide the way that we provide treatment, that can potentially reduce our reliance on these biases. And another thought is just really, there are some researchers who argue that we shouldn't be focused on implicit bias at all, because it's too difficult to actually change people's biases. And so these researchers say, instead of focusing on implicit bias, what we really need to do is focus on reducing discriminatory practices. We can't change how people think because they're not even aware that they're thinking about it. But what we can do is actually address discrimination within our institutions and our organizations. And by disrupting that, we can reduce the number of adverse outcomes that we see. And so the researchers who actually created the implicit association test published a paper last year that really talked about the importance of addressing discriminatory bias as opposed to actually trying to reduce implicit bias. They really see this as a public health problem in which our focus should be on reducing discrimination rather than reducing implicit bias. And they talk about a few ways to think about that. And so the first thing that they suggest is that it's important for organizations to identify and find disparities. And so it's important for organizations to actually use data. There's an old saying, you can't find what you can't measure. And so it's really important for our organizations to actually use all of the data that we collect. So all of our organizations collect data on demographic characteristics. They all collect data specific to health outcomes that they care about. And so it's really important for organizations to look for disparities, to determine where the disparities are, and to identify them among the people that are getting services from our organizations. Secondly, they focus on talking about we need to decide if we see disparities, are they actually related to discrimination? So first of all, are these disparities real and are they large enough for us to actually care about? So we may see disparities by only a couple of percentage points, and perhaps those disparities are not large enough to prompt concern. But if we see wide gaps based on race or sexual orientation on gender with respect to certain health care outcomes, then perhaps that's a case where we need to actually pay attention and try to understand more about what that disparity looks like. Second, they encourage us to really think about whether that disparity is due to discrimination. And that's not an easy task. But what they recommend is that in order to make that decision, we really have to think about if there are potential explanations that may not be related to discrimination. So can we rule out other possibilities for why we see gaps in patient outcomes? If we can't rule out other possibilities, then it's really important for providers and institutions to really think about whether discrimination can be a root cause for the disparities that we're seeing in our data. And then third, they really talk about the importance of creating policies and protocols to reduce discrimination. And again, standardization is a really important part of that. The more that we have clear guidelines for how providers engage with patients and the ways in which providers should treat patients, the better off we'll be in terms of reducing risk of discrimination. They also recommend that we really think about DEI and prioritize DEI efforts throughout our institutions and organizations. So it's not enough to have a director of diversity, equity, and inclusion just as a figurehead. It's really important to have an office dedicated to diversity and equity and inclusion that's constantly evaluating data and identifying potential disparities and outcomes. And additionally, having an office like this that really is constantly looking at data. So we're not looking at data just one time to identify potential disparities. We're assessing and reassessing. You know, if we identify a disparity and we create policies and protocols to reduce discrimination, are they actually working? Are we actually reducing the disparities? And if not, why? What can we do differently? And so it's really important for our healthcare institutions to think about these issues and have staff dedicated to these issues at all times in order to really assess how well the organization is doing in terms of its responsiveness to diverse populations. And so in conclusion, I'll just leave you with a few talking points. First, implicit bias. I hope that you've learned by now that this is a very real phenomenon, but that is something that we're often completely unaware of, which is why it's so difficult to reduce it. But we know that this bias really does impact how we treat people and how we provide care. And so the evidence really related to this bias shows us that there are some individual level strategies that we can use to address this bias, but really addressing this bias requires institutional change. And the leaders of our organizations really need to work and invest in diversity, equity, and inclusion in order to reduce the impact of this bias. And so with that, I will take any questions or comments that any of you have.
One, I want to thank you for having pharmacy specific examples. We as a profession are trying to deal with this, and our students are reflecting and attending these programs to grow. Students sometimes struggle with what their personal cultures believe, and then providing care to patients where their personal cultures might not believe in that sort of practice or identity. How should those students work through their conflicts between providing care and their cultural background?
Well, I think the goal is really recognizing that your goal is to be patient-centered. When you're having an encounter with the patient, it's about them more than it is about you. So having that patient feel comfortable is going to really be beneficial to you when you're trying to provide care. And people are comfortable when they're surrounded with experiences that reflect their culture, when they are being treated by someone who understands and respects their cultural practices. So even if something isn't necessarily aligned with what you believe, it's important for building trust for you to really respect and accept the culture that your patients come from. So if you're thinking about this as something that's supposed to be a patient-centered experience, that really should trump any cultural identity that you're bringing into the situation, and really respecting that person's culture is the most important thing. And I think also with that as well, just thinking about the fact that you can learn from your patients as well. Like our minds can be fairly plastic, and we can learn about other cultures and have an appreciation of other cultures that we may not have even thought of previously. So sort of learning how your patients come to be who they are, and the way that their culture sort of shapes who they are, I think just makes you a better provider and helps you to sort of listen and understand and have more empathy for your patients when you recognize their cultures and respect them.
I can like stop the recordings if anyone wants to ask questions like off the recording.